Well, good afternoon, everybody. Thank you so much for joining us for this webinar, the first of many that's going to happen over a period of time. We are so excited to have people who are going to present, who will be introduced by our host later on, who will bring very valuable input into the different topics that we will be covering. Today will be on medically speaking on issues of health. And I'm not going to talk to that necessarily, but just to say to all of you who have joined us, we welcome you and we encourage you, please, to let others know about this platform. You know, one of the things I find very intriguing because of the line of work that I do as a minister and being in contact with people involved in counseling and traveling around the country, is to note how so many of our people, if there are things they could just be in the know about, receive information and that information presented to them in a way that they could interact with that information, we would spare ourselves from so many things that happen to us. The topic of health and issues around the medical area. There are certain things, even when you read the Bible, which are just natural principles. If people were to just apply, they would avoid sickness and disease in their lives. And I think this platform is going to be extremely empowering for all of us in all areas of life, because wellness is what God wants for every one of us. In the Epistle of John, when John writes, I have no greater joy than to know that my children walk in the truth. And then later he says, I wish above all things that you may prosper and be in health, even as your soul prospers. God wants us to do well. God wants us to prosper. God wants us to be on the victory side. But that is in direct relationship to the prosperity of our soul. The prosperity of our soul includes the knowledge we have, the renewing of our mind, the way we think, but all of that is informed by, it is dependent on the information that we receive. So I want to encourage all of you, please, to participate, listen as best as you can, pose your questions, and we pray that God will bless our presenters and all of God's best and all of God's blessings on this process. And I really want to say thank you so much for having me. I'm going to hand you over now to Dr. Nolitando, who's going to be the host. God bless you all.
Thank you.
Thank you so much. Thank you so much, Bishop. And good evening and good afternoon. Maybe it's still afternoon. Good afternoon to everyone who is streaming or watching this first webinar of many. I really just want to acknowledge the leadership of the church and say, indeed, we are led because it's such initiatives that allow us to be socially relevant as part of our slogan as the church, as a church that dreams. So this is really about social relevance and making sure that we reach people where they are. So we really are privileged to have had our bishop launching this first webinar for us. Tonight, I am joined by our experts from GBC. So it's actually such a privilege to be, to have experts of our own within Grace Bible Church. So I'm joined by Dr. Talita Daugubong, who is going to be coming from an oncology point of view. Also joined by Dr. Mishak Mbokota, who is part of the leadership in the church, but also he is a gynecologist by training and profession. And we've got Dr. Jackie Tobane, who is, he leads our medical team, our EMS team nationally, but also he himself is a dermatologist by training. So this is our first webinar. We're gonna be, while we said it is medically speaking, but we do have a specific topic that we're gonna be covering today. September is Cervical Cancer Awareness Month. So we felt that it was important for us to raise awareness around this very important cancer. So why is it important for us to have this discussion about cervical cancer? So firstly, it's a preventable disease, but more importantly, it is the second leading cause, common cancer in women in South Africa, and the fourth common cancer in the world. And it is one of the leading causes of death in women. So when we think globally, it's over 600,000 people who are diagnosed annually with cervical cancer, and about 350,000 people die of this cancer. In South Africa, we know that over 10,000 people are newly diagnosed every year with cervical cancer, and sadly, about 6,000 people lose their lives to cervical cancer. So that's the importance of us focusing on this topic. So now I'm going to bring in my experts to actually help me unpack what cervical cancer is about. So we'll start by just saying, firstly, what is the cervix? I think the best person to answer that question is Dr. Mbogota, who is our gynecologist. I think, he has learned about the cervix and knows the role of the cervix more than most of us. So Dr. Mbogota, over to you. Let's understand where the cervix is, what it is about, and then we'll unpack it further.
Thank you, Dr. Nolutando, and thank you to the viewers, and thank you again for the opportunity to be able to serve. Just as a way of introduction, a cervix in simple terms is the mouth of a womb. Now, if you, maybe just to put a few disclaimers. In my profession, in obstetrics and gynecology, a spade is a spade, it's not a big spoon. So we're going to call a spade, and so that there's no confusion about what we mean. So if a lady is to put her finger into the vagina, right up, she will feel something as soft as the tip of her nose. That is actually the mouth of the womb, that is the cervix. It has a very peculiar function. The first function is to remain closed during pregnancy, to keep the pregnancy inside. And then at the time of labor, it's supposed to open so that the baby can be delivered. You can then note that then based on where it's sitting, it actually peeps into the vagina. And because it peeps into the vagina, it becomes exposed to just about every other inflammation or infection or bug or any activity that happens inside the vagina, including sexual intercourse. And so because it gets exposed to that, it is vulnerable to viral infections, it's vulnerable to bacterial infections. And in the case of cervical cancer, the changes that occur on the mouth of the womb, on the cervix, are actually the things that we watch out for to see if those things could become cancer or not. So that's in a nutshell what the mouth of the womb is, or the cervix is. It's the mouth of the womb, is the lower part of the womb, as opposed to the body of the womb. I think in a nutshell, that's what it is. Thank you.
Thank you so much, Dr. Mbogota. So generally, what is its role? Why is it there? So, people will be like, okay, yes, it is the mouth of the womb, but maybe some of the important aspects, because it does play a role. So, for example, in pregnancy, why do we have the cervix? What does it do?
So in pregnancy, what tends to happen, conception occurs, meaning the egg and the sperm, they meet somewhere in the tube, and they walk down the aisle and they go and implant in the womb. Now, the role of the cervix in that is to make sure that the sperm can pass through and then goes right up to the womb, into the tubes, to be able to fertilize the egg. If the cervix has got some antibodies against sperm, it will cause infertility, and that's the one role. Then the next role is that it must then keep the pregnancy inside for an average of 280 days, which is, we call it 9 months, but it's actually 280 days. And at the right time, it must then open. So if it opens before, you get a premature labor. If it opens very early, you get a miscarriage. So that's really its function, to keep the pregnancy inside, and also to make sure that at the time of labor, it opens up for the pregnancy for the baby to be delivered.
Great. So now we understand this is not just a useless part of our body. So it's an important part of our body that is responsible for various roles during pregnancy and during conception, and just generally in terms of just the woman's wellness. So I'm gonna bring Dr. Talita Daukubong, and just for us to bring these two concepts together, so we understand about the cervix now, but now we are addressing cervical cancer. So what is cancer in general? What is cancer?
Okay, so cancer is basically when we have abnormal cells that are growing and are dividing so rapidly that now the normal nature of a cell in the body cannot keep up anymore to eliminate these cancer cells. So what ends up happening is that they're so overwhelmed that we end up having cancer cells. And these cancer cells at the end start not only spreading to tissue, but also spreading to other organs. So they can go anywhere in the part of the body. So they, in like cervix, for example, because we are focusing on that, as Dr. Mbokoto explained so nicely, it's in the cervical os. So our division and all the abnormal cancer cells are within the cervical os. So what happens is that you can progress from stage 1 right through to stage 4, where these abnormal cancer cells have now spread as far as to the lungs. It can spread to the bladder. It can cause renal impairment and cause so much disruption that we now say this patient is metastatic, meaning that the cancer has gone beyond the cervix, the cervical os. It's gone to other organs. That's what cancer is in relation to also cervical cancer.
So thank you so much. It's abnormal cells that really just cause so much havoc. Thank you for that. So, when we think about cancer, people are thinking death. Once you mention cancer, then it's dying. But we do know, which is why we're here today, that, we can prevent cancer. And we know, I think in literature, it says about 40% of cancers are preventable. And also some cancers are actually curable. So I'm going to bring in Dr. Jackie Tobane now to say, we speak about prevention of cancer, we speak about screening. So maybe let's just unpack that a little bit. How can cancer, specifically cervical cancer, be prevented? So we'll speak about preventing it from occurring and then also picking it up early as secondary prevention. So maybe let's unpack that a bit. So how can we prevent cervical cancer?
Thank you, Dr. Nolitando, and thanks to the presiding bishop. Thanks for the question. Yes, prevention is very key in this topic that we're having of cervical cancer. But obviously, when we speak about treatment, it means we are now at the early end of the disease, which is not where we want to be at. Where we want to be is to be at a preventative space. Prevention, what of importance is that when we talk about prevention, we are actually looking at a person who is asymptomatic, a person who is not having a particular disease. So that is where we are when we speak about prevention. Of importance, our topic today is on cervical cancer. Let's start at the elementary level. Thankfully, our government is assisting in helping us to come with modalities in terms of prevention. We'll remember, or we may not, in the year 2014, there was a drive that was introduced at school level, which was an HPV vaccination prophylactic drive. This is actually, we all know that as children, we need to have, we normally have our immunization card. We need to be immunized from different types of diseases that can be preventable. We are now at prophylactic level. So there's a new vaccine that has been introduced at the school level. The aim is to make or to have all the girl children at about 15 years to have been vaccinated. They started in the year 2014, but as we all know, COVID came and then there was some stall in most of the things. But we are now on course to escalate that drive. So that is prophylactic vaccination for girl children. Like I said, that the aim is to have them vaccinated at least by the age of 15. We also have a number of methods, screening methods that can be utilized for us to be able to avoid we having this condition. We are still at prevention. We all know about the pap smear or pap test. I'm sure most of us are familiar with that. And there are other new modalities. I've mentioned the HPV vaccine. There's also a new method, the HPV testing, that has been introduced. I believe later on to Sambagoto, we may have a word or two to explain and to expound on that. The initiation for the vaccination testing is recommended at age 25. And thereafter, we are now venturing in the space where people may be symptomatic for cervical cancer. In that case, pap smear will be mandatory. But before we come to that, we normally have every organization, every structure, even in our church, we have structures that we abide by. So equally so in the gynecological space, there are guidelines that we adhere to that guide us in terms of how we need to move on in terms of doing some, in this case, screening. I'm talking here about pap smear. The guidelines recommend that at the age of 30, all women should have their pap test done. And then at the age of 30, just to simplify it and to make it simpler for all of us, we say that at the age of 30, pap smear needs to be done. And from there, we say 3 cervical smears in 10 years. That should be able to cover all women. However, our society, even in our church, we have a blended or a mixed community. Because of importance, Bogoto mentioned that among other things that may cause cervical cancer is intercourse. So whilst we talk about the guidelines and they talking to us starting pap smear at age 30, because of a blended community that we're having and because of the different profile risks that our population may have, at times there might be a need for us to deviate from the normal guidelines, in which case, depending on the risk profile of a patient or comorbidities, pap smear may need to be done earlier. Thank you for now, Tando.
Thank you so much. I think you've given us the overview. Now I'm going to bring Dr. Mbogota to discuss the the HPV vaccine. And I think maybe Dr. Mbogota I think the important starting point is, what is HPV and why is it important in this conversation?
Okay. Thank you. HPV stands for human papilloma virus. So this is a virus that generally causes warts in Zub. And there are different types of these viruses. It's got subtypes. And there are certain subtypes that have been found consistently. Where cervical cancer is, those viruses are generally found. So they are now deemed to be the ones that are most likely causative in creating those changes in the cells that become abnormal and they start multiplying abnormally. I see there was a question earlier of how does these abnormal cells come about. So what has now happened is that the advent of a vaccine for this, we call them oncogenic subtypes of HPV. Oncogenic meaning they can start cancer. So there are two types of vaccines, but in the public sector, as of I think 2 years ago, there's an agreement that there is one vaccine that is being used and there's one dose that is being given. In the past, it used to be 2 doses, so there's one dose. And without having to sell anybody's vaccine, we will not mention the name, but it's one dose that's given. It provides sufficient cover. Now, the idea is that you need to try and immunize all the girls, because it's only girls that have got a cervix and that are therefore most likely to get a cervical cancer. And generally, they would then start this vaccination from around when they're in grade 5 onwards. And the idea, obviously, is that it's done at school, and the parents have to give permission for that. Now, that's the first part about HPV and the vaccine. Now, HPV and screening. So Dr. Tovane spoke about a pap smear. A pap smear is a cervical smear, which a number of women are used to. It terrifies them most of the time because they think that if it comes back abnormal, it means they've got cancer. But a pap smear is when we collect cells from the mouth of the womb. In the past, we used to put them on a slide, but these days we put them in some liquid formulation, send them to the lab, and then the lab looks at them. And in there, we look for changes in the cells, which, if not dealt with, they may progress and become cancer. And I think it's an important thing to know. So, so the cells that we're looking for, we call them pre-malignant or pre-cancer cells. So those cells are not cancer. But if we do nothing about them, then they are more likely they will continue and creating those changes and subsequently become cancer. And that's an important part of prevention, because if we're able to find those cells at that stage, as you said earlier on, this cervical cancer can become curable, because the treatment then is to treat and deal with those cells. And more importantly, the woman can maintain her fertility. The womb doesn't necessarily have to be removed.
Yes.
Okay.
Yes.
And then thirdly is that, so one of the things that has now come up in terms of science is that we've found out that because it's always difficult for women to go and have this pap smear and have this big piece of metal put in there, or these days was a plastic, very, people are afraid of it, literally. So you can self-test as a lady. You can self-test now. You can actually go to a chemist. There's a collection kit. You take that kit. It's got something that looks like a tampon that you can put inside the vagina for a few minutes. Take it out, put it into the container, write your doctor's name and your medical aid if you've got medical aid, and then it gets sent to the lab and the results come back. If the results come back and says you've got no HPV, then you are good for the next 5 years without having to repeat the test. So I think that's the importance of human papillomavirus, or HPV, and how it has now come to a point where we see it as the biggest risk factor. There are other risk factors, and for the mothers who are here and the young ladies who are here, the biggest risk factor in our country, it's early initiation of sexual intercourse, and it's also multiple sexual partners. And I must clarify it. It is not multiple sexual partners concurrently. It's the total number of sexual partners that you're exposed to in a period of time that influences those changes in the mouth of the womb, and that becomes cancer. I think I'll leave it at there for now.
Yeah, there's still a lot to cover. Dr. Mbogota, but you've unpacked this nicely. So I want us to almost put the vaccination to bed. I think you've covered it. We know what human papillomavirus is. We know that, our young girls need to be vaccinated. I mean, there's a bigger topic. I know parents say, what about our boys? I mean, you've addressed the fact that for now, let's start with the girls. They've got the cervix. Yes, ideally, when finances allow, we could vaccinate everyone, including the boys. But I think the primary important target population right now is the girls. And you've indicated that they must be vaccinated. I think Dr. Tobane said before the age of 15. And we know right now the target group is the grade 5s. I think they're around 9 years. And there's a single dose. I think, Dr. Mbogota, you didn't want to mention the name, but I will mention the name of the vaccine, and I'll tell you why. Because there's a lot of conversation, specifically in some sectors of community where people are quite exposed to these names. So the one that is available in the government sector is cervix.
Yes.
And there is, there is data that has been shown to say that one single dose is sufficient, to provide protection. Whereas there is Gardasil that is available. The cervix has got 2 strains, which are the most important ones that are linked to cancer. Whereas Gardasil might have much more. I think it will have about 5 strains that cover many other, subtypes of human papillomavirus. What I do not want people to live here feeling is that what government is providing is not sufficient. I think we need to leave here feeling that what is currently being provided for is sufficient for prevention of cervical cancer. So that's the first part. And then you spoke nicely about, prevention, and we spoke about the screening. And I think Dr. Tobane spoke about the age of starting to screen, which is age 25. And you highlighted that most people are familiar with the pap smear. And I think when we think about cervical cancer screening, people think about this pap smear. We know the limitations of the pap smear, the fact that it is uncomfortable, the speculum, the metals and the plastics that, we use to go and pick up those cells. But you've mentioned something very important about the newer ways of collecting the sample. So you're collecting the sample now using these self-test kits. So you're self-sampling. So it's not a test itself, it's just a collection kit. You're collecting the cells to send to the lab for the lab to actually then test for HPV. You can buy these, get them from the pharmacy, and the pharmacies usually have boxes that are there where you can then go and drop it off, and then the pharmacies will pick it up. You can also collect these from your doctor's rooms. Doctors who have got access to these will be able to provide them to you, and you can drop them back at your doctor's rooms, or you can still drop them back at a pharmacy point. So I think that's important. We've covered now the prevention aspect. And I think it's important to also highlight that WHO, which is the World Health Organization, they would like to see cervical cancer being eliminated by 2030. So we are now in 2025, meaning that it's in 5 years' time, where they want to see the world in a different space. And I mean, other countries elsewhere, they're on track to actually get to eliminating cervical cancer by 2025. So, which is why we are here today. We don't want to be left behind, because it's such messages that actually allow us to get closer to eliminating, cervical cancer. What we have not spoken about is the relationship between, I think, Dr. Mbogota, you've started speaking about multiple sexual partners and all of that. But in South Africa right now, the biggest link to cervical cancer is HIV. So HIV is strongly linked to cervical cancer. And I think even our screening is slightly different compared to a person who is not living with HIV. So maybe I'm going to throw it back at you again to say you've already highlighted the risk factors. But if you were to then speak to someone who's on this call who may be living with HIV, what would you say differently in terms of the message around screening?
Okay. Firstly, with HIV, as we say, it is the great pretender. So what has happened is that every screening program, the screening becomes much more regular with HIV, simply because HIV and its it reduces the person's immunity. And once your immunity is down, the cancer cells basically, they become quite aggressive. And it is with HIV where we see younger women actually getting higher stages of cancer, or the cancer progressing much faster. Even the pre-malignant lesions in the context of HIV, they progress quite quicker. But I must hasten to say that those people who are on antiretrovirals, who are taking treatment, where the viral load is now stabilized and the immunity is better, are at a better chance. So theirs is a slowdown, but it's not yet almost equal to the person who's HIV negative. So I think for anybody, and because in this case, we do have people who've acquired HIV when they are adults, but we also have people who were born with HIV because of where we are now since the advent of HIV in the late 80s and the early 90s. So I think that's the key thing as one of the risk factors as HIV. Thank you.
Thank you so much. Thank you so much. I'm glad we covered that. Dr. Dabukubong, somebody here might want to know, so what are some of the signs and symptoms of cervical cancer? So we spoke about screening, meaning screening, you're screening people who don't have symptoms, but there may be somebody who's saying, how do I know if I maybe already have signs that could mean that I should be going and getting some help or someone to check me out?
Okay. So there are some signs and symptoms. The symptoms that the patient will experience is, one, they'll have this abnormal PV bleeding. They'll be on their periods, but for some reason, it tends to come back and they start spotting. Others report that they start spotting. That's one. They have an abnormal discharge. It's normally very foul smelling. It doesn't smell pleasant. They also complain of dyspareunia, that will be pain during sexual intercourse. They also, some others are complaining of post-coital bleeding. That means they are having bleeding during sexual intercourse, which is very, very important. It's actually a very important sign, an early sign that women normally miss. And some in their later stages now start having this lesion that they actually can feel. They can actually feel it in the cervix, and they can actually feel it coming down through to their vagina. There's a lesion that they are picking up, but that's normally in its later stages. And then of importance is one very, very important thing is that they also complain of now starting having urine passing through, sometimes feces also passes through the vagina. Now, those are normally our late stages, and those are our stages that indicates to the clinician that this is stage 4. So those are the type of symptoms that they complain about. And then in general, they lose a lot of weight, and they have the typical night sweat, sweating profusely. We call them constitutional symptoms. Some coughing and some, as I said, weight loss. So those are the type of symptoms that they are generally complaining of, and it's actually quite of importance. I just want to speak to that in terms of our screening, we're actually failing our patients because we're not screening enough, and we're picking up diseases, the cervical cancer, at a late stage. I speak to the clinic that I work under, radiation oncology. We are seeing cervical cancers that are presenting in stage 3 and in stage 4. And we'd like to catch them earlier. We don't want to catch them at stage 3 because now the prognosis, when I say prognosis, the outcome becomes poorer, and there's so much to do for our patients, but I feel that we are not catching them at the right time.
Wow, thank you so much. Considering that, I mean, cervical cancer is a slow growing cancer. So it's not like by the time you are in stage 4, it means it has been growing over the years. So it means the importance of screening cannot be overemphasized. And I think, I mean, Dr. Mbogora spoke about the early cells, the changes in the cells that are not even cancerous as yet, that can be treated to prevent cancer from happening. So maybe just to recap, you spoke about bleeding. So it's almost like a period, but it's multiple times you're seeing your period coming back multiple times. You spoke about the vaginal discharge that is foul smelling. You spoke about a pain, pelvic pain, in your lower abdomen. You spoke about deep pain when a person is having sexual intercourse, and you spoke about also bleeding, during sexual intercourse. So I think you've covered most of the symptoms. And yes, there are some of the scary ones when already the cancer has spread and it has really caused more damage, where you start now seeing feces and urine coming out of the vagina. So I think we don't want to get there. We don't want to get there. So thank you so much. I think we did touch on who's at risk, and I think Dr. Mbogota, you've covered that. We are comfortable. So maybe then let's talk about firstly, maybe let's unpack, Dr. Tobane, where can people go and screen so that we can just close this off? So we've spoken about, picking up the self-sampling kits. Is there maybe any other guidance we can provide so that people say, okay, after this webinar, I want to go and screen? So we can say, go and pick up your self-test kits from the pharmacy. Some people may say, well, I don't have money to do that, or I don't have an understanding of how that can happen. I don't have a medical aid. I don't know what's going to happen with my test. So maybe let's advise and guide around screening so that people live here feeling, I know what to do after this webinar.
Thank you. I think for us, the easier one is for, I think most of our communities have local health centers. So people are advised to contact their local clinics, health facilities, to inquire about the screening facilities that they have. We also have, most people, well, not most, but some people may have their family doctors. They can go to their GPs and to inquire about this test. Also, people can also go and contact their gynecologist also to get the same facility. We also have the Cancer Association Center. They can also contact them, and then they can also advise as well in that regard. Otherwise,
Perfect. Perfect. Thank you so much. I think I'm also picking up some questions. So I want to almost make sure that we weave in some of the questions into the discussion, especially when they relate to prevention. I think the question is, besides the vaccine, what else can you use for prevention? And also, if you've already removed your womb, is this something that could help you prevent cervical cancer? I'll throw it at you, maybe Dr. Mbogota.
Yes, as we say, the vaccine is used to prevent infection with HPV. So if a person doesn't want to take the vaccine, and that would be their right to do so, then it means they have to then subject themselves to this annual, to this regular screening, either as the routine old pap smear that we used to do, or doing the HPV screening, which with a self-test kit, or as HPV screening from your either the clinic or the general practitioner or your doctor who would do that. And that on its own is to assist us to pick up the cells as they change, and that in a way it's a preventative measure. The second question that relates to whether removing a womb will prevent cancer. The reality of the matter is that if the womb is removed with the mouth of the womb, with the cervix, then yes, you are likely to prevent it, provided when the womb was removed, it was removed for something else other than the abnormalities on the mouth of the womb. Because if it was removed because there were abnormalities on the cervix, there may be small little cells that are left in the roof of the vagina. And that person then would still need to have a screening, meaning we call it a vault smear, to try and make sure that those little cells do not recur on the roof of the vagina. But you don't want to use a bazooka to kill a cockroach. So we're not gonna remove a womb simply because we want to prevent cancer of the cervix, because the converse is that will we remove your breast to prevent cancer of the breast? So I think those are, and we must remember the significance, the sentimental significance of a womb in most women and in most of our cultures. So yes, if you remove it, it helps because it has got all of those. And if not, let's just continue screening.
Thank you so much, Dr. Mogot. I wanted to share something because one of the questions is whether only high-risk girls should have the vaccine. I think, there's an interesting, report coming from one of the Norwegian countries where they followed up girls who received the vaccine and now they are, early adults, and none of them have actually had cervical cancer, which is exactly the path that we want to go through to make sure that we do get elimination of cervical cancer. So what's important is that all girls should get their cervical cancer, the HPV vaccine before the age of 15 for us to reach that goal of eliminating cervical cancer.
Yeah, but just also there, it's very difficult to determine a high-risk girl below the age of 15. It's extremely difficult because you do not expect them to have started having intercourse. Yes, you can find those who were born with HIV, who are HIV positive, but the ideal is clearly to give all of them to basically to try and eradicate HPV as a viral infection.
Yeah, no, thank you so much. I just wanted to also maybe bring in what Dr. Daukubong mentioned around, some of the cases she is seeing in her unit. And we know from a survival point of view, if it is picked up early, the survival, 90% of people will still be alive in 5 years, which is what we refer to as 5-year survival, at least over 90%, whereas just under 20%, if it is picked up late, will be alive in 5 years. So the importance of picking up the cancer early we cannot overemphasize. But now let's maybe discuss the treatments because obviously there are different treatments and obviously it will also depend on the stage at which we have picked it up. Dr. Taukubo, let us know, what are the different treatments?
Okay. So in terms of treatment modality, depending on the stage at which you are at, I will speak to the surgeon to discuss his part. That's Dr. Mbogot. I'll leave it to him for the surgeon. But what we normally do when we get referred from the surgeons, we do see stage 1, B3. Don't worry about the technical part of the B3. It's for us. And we do see a lot of stage 2. And some have surgery, some are unable to get surgery in a stage 2. And then we as radiation oncology, this is where we come in. Let me just give a little bit of background history on radiation oncology. So what is radiation? Radiation is basically now, it's a high energy treatment in a form of X-rays, or sometimes we call gamma or charged particles. So what we do, we offer two aspects, which is external beam radiation, which is externally, meaning outside, and also something called internal, which is brachytherapy. So in terms of our patients, let's say, for example, I'm going to speak to stage 2. In a stage 2 who's not operable anymore, or sometimes is operable, they come in, there are certain parameters that we look at, and we give either adjuvant or definitive RT, it's radiation. So don't worry about the big words. I just want to explain what we actually do. So in stage 2, as I said, we do give radiation, and our radiation is what, let me take you through in basic day-to-day what I do. So we would clock the patient, referred from the gynaes as a stage 2.
Oh, what is stage 2, Dr. Talita?
Okay.
Okay, so stage 2 has it's within the parametrium, right? Now that's why I say I want to
All
give
right,
it to Dr. Mbogoto to deal
yeah,
with
let
the
me
of
come in there. Let me
gynae.
come in there
That,
so
Yeah,
that
please
we,
help us.
yeah. So in simple terms, when the cancer is confined to the cervix, to the mouth of the womb, we call it stage 1. Okay? When it has now extended outside the mouth of the womb, but it has not gone to the lower parts of the vagina, we'd call it stage 2. When it involves parts of the pelvis, the walls of the pelvis, the rectum, and the bladder, we would call it stage 3. And then when it is spread right through the body, we would call it stage 4. That's a simple classification for the purpose of this discussion. And then in terms of surgery, the majority of stage 1 patients, and I'm saying majority, not all of them, can be then treated surgically by a gynae-oncologist who does an operation. We used to do some very long operations and remove lymph nodes and all of that, but they can be done surgically. Those lymph nodes are tested. If cancer cells are found in those lymph nodes, then these people are then sent to the radiation oncologist to subject those people to radiation. So I think in a nutshell, so that's what. So anybody from stage 2, from a certain part of stage 1 and stage 2 onwards, then gets different kinds of radiation. There is radiation that we give to try to cure the disease, and there's radiation that we give just to control the disease, to give a person comfortable life. I think we call it palliative radiation. I think then I will leave it to her.
okay.
Thank you so much, Dr. Mbogota. Yes, Dr. Takuba.
Yes, thank you. So as he highlighted, we have a definitive treatment. Okay, that's a curative. We aim to cure you. And then we have palliative, where now we're not aiming to cure you. It's because you are now in the later stages where we cannot now cure you anymore. We palliate you. So we palliate you for different reasons. We can palliate you for pain and also try to shrink the tumor a little bit because it's a very vascularized. It means a lot of blood vessels, the cancer. So it tends to bleed a lot. And that's where we say also the palliative aspect of it. So in terms of curative intent, it would take us basically 6 weeks treatment. 6 weeks treatment. And this is how the step by step, I want to explain step by step what we do. So first day, we would scan you, ideally, in the ideal world. We scan you with our machines. Then we will scan you in a way we take your imaging and all those images and we compile a treatment. We say we're drawing a volume. We draw treatment for you. Now, that treatment, essentially, remember I spoke about external beam radiation outside. We're going to treat that cancer outside, directed to where your cancer is, whether it's a stage 2 or it's a stage 3. Then after that, after the 6 weeks, which is Monday to Friday in our settings, we don't do Saturday, Sunday. We give you time to recover. Then this goes on for 6 weeks. The tumor is shrinking. You get the clarity. We ask questions. We'll ask how is the discharge. So normally they'll start telling us the discharge is much improved. 2, how's the bleeding? The bleeding is actually stopped at a certain time period, and the discomfort, the pain, actually they respond well, and it actually goes away. Then at the end of that 5 weeks, let's say, on the 6th week, we now come in with something called brachytherapy. So we're taking radioactive substances and we put them in a form of tendons and ovoids inside the cervical os. Remember the mouth of the cervix? That's where we are now directing inside to also catch any other tumor that we missed from the external radiation. And that's how we complete our 6 weeks treatment. And then the importance of that is that we also give chemo concurrently. When I say concurrently, meaning that within the week that they're going Monday to Friday for radiation, in that week, once a week, they get chemo. It's called a cisplatin chemo. So sometimes people have greatest fears about chemo, saying, "Oh, my hair's going to fall off. I'm going to be feeling sick." Yes, but not so badly. We encourage patients to have the chemo together with the radiation. Reason why is that they have a better outcome. The chances of the tumor, of the cancer coming back, becomes less. So together with the chemo and the radiation, they work synergistically, meaning they work well. They have a good relationship in reducing also the reoccurrence of that cancer. And then we follow them up 6 weeks times 2 and then 3 monthly. We normally link with the gynecologist after that we see them together. We give them 3 months so that we don't lose them in the system, because cervical cancer has a way of coming back somehow. Not in every case, but in some cases they do. So it's important also to follow up those patients.
Wow, thank you so much. So I'm going to try then and consolidate this information and say, so depending on the stage, we say when it's still just there in the cervix, you can remove it. And usually, if it's early stages, you can remove it, and then you have cured the person. So majority of the cases, when they're picked up early, still in stage 1, you can cure. So you said, Dr. Mbogota, then there is local spread. So there you're saying, while you can be able to remove, and I think Dr. Talita, you spoke about adjuvant radiation and all of those things. So let's unpack it for people. So because you can still cut it out, but it has spread a little bit now, you can add other things to burn the other cancer cells that could still be in the system. So you burn them with radiation. Ne? But radiation, because you're burning the cancer cells, but you're also burning normal tissue, you may have some side effects, ne? Which is why people who have gone through radiation, they can have these side effects. But then we spoke about, cancer spreading to other parts of the body, which is why you want now to not only focus on the local aspect of the cancer treatment, but make sure that you deal with the rest of the cells that may be going into other parts of your body, which is where chemotherapy comes in as well. Because chemo is systemic, so meaning it goes into your bloodstream and it will cover all the other areas where these cancer cells could have gone to. So it's those 3 modalities, surgery being a curative intervention, especially if it's picked up early. Radiation can really focus on the area where the spread is, and then chemo goes to the rest of the body. But all these interventions are really about getting rid of the cancer cells so that your body can be fine. But usually towards the end, when it is picked up late, we can't be in a curative stage anymore. So I see people saying, you know what, it's quite nerve-wracking. I think the important message here is that if we screen, in fact, let's start by, if we vaccinate our kids, our girls, make sure that we prevent cervical cancer, or if we can't prevent it, we pick it up early, we can actually get to the 2030 target of eliminating cervical cancer. So I think what we're hearing is scary because a lot of people are not screening, and by the time they get diagnosed, they are now in those late stages. Let's just see if there is additional information coming, in fact, questions coming from the chat. I think the one question, Dr. Mbogota, that has come through is whether the vaccine can still be administered to adults.
Yes, that question always comes up, and we say that if those adults are HPV negative when you do the HPV test, then you can still offer them the vaccine, even though its protectiveness reduces as they get older. But they must be HPV negative, so which means they must have done the HPV test and it must be negative. That's the one question that come up. I think I just need to address 2 other questions that have come up. One is that endometriosis and polycystic ovarian syndrome are not causes of cancer. They don't cause cervical cancer. They are not related to cervical cancer. The symptoms may be similar in terms of the bleeding patterns, but they are not related. So if you've been diagnosed with those are different conditions. But that doesn't mean that if you have them, you do not go and screen. And that's the reason why the screening has to be done. In the past, we used to say at any opportunity that we come across with a female patient, we would do screening for cervical cancer, meaning that when people go for their routine contraceptives or hormone replacement therapy and so forth and so forth, so that we can hopefully reach this milestone in 2030 where we were able to eliminate the disease.
Awesome, awesome. Sure. We are almost close to wrapping up. We've got 6 minutes left, and I think, we've covered most of the points that have come through the chat. I think as we get to wrapping up, I'm going to bring you back, Dr. Tobane, and get your closing remarks before we close the session. Just your key message to our congregation here, the luckiest congregation on this in South Africa, because your bishop and my bishop love you so much that they want to make sure that you are part of those people who are leading the elimination of cervical cancer in our country. So, Dr. Tobane, what are your closing remarks before we close?
Thank you, Dr. Nolitando. I think maybe as I close, I'll just touch on what Zambogoto touched on earlier in terms of the risks that predisposes people to cervical cancer. He did mention that early start of sexual intercourse is one of the commonest causes, multiple sex partners, and also sex partners with multiple partners, co-infection with other sexually transmitted infections. We know about the gonorrhea, syphilis, but obviously in our setting, HIV is the most critical one. And immunosuppression, this also, HIV may cause immunosuppression, but also in some other settings, nutrition may also cause immunosuppression. Some medications, what we normally refer to as being immunosuppressants, these are medications which treat particular diseases, and those particular diseases need those immunosuppressants to be used to take care of those diseases, because if you don't, the fatalities are worse. But however, those medications may also account for immunosuppression, and elsewhere in some other patients, those who are on organ transplant, they may also be immunocompromised. Commonly in our society or population, smoking also contributes to cervical cancer. Other contributing factors may include, this may not apply to our setting, but socioeconomic status, which talks to urban versus rural areas, in that access to services may be a challenge in those communities which are challenged socioeconomically. And therefore, this talks also to the availability of tertiary care. We talk here about availability of services like oncologists and some specialists. In those disadvantaged communities, access may be a challenge. In some other settings, educational levels may be a factor, because in most cases, communication that is being done is mainly in English. So not all of us may be able to comprehend. Obviously, work still needs to be done from government's point of view or setting to include all languages so that information can be all inclusive. Social arrangements of other families, certainly so, wherein some women are not decision makers, they still rely on their male counterparts in terms of them taking care of their sexual and reproductive issues. Like I said, unfortunately, it still happens elsewhere. And also in cases where they rely on their male partners, so the male will have the saying in terms of them going for these essential test screenings that we have been talking about. Also elsewhere, you find that females or girl children rely on the elderly women to get information, and you find that the elderly women are themselves inadequately informed in terms of enunciating the topic of cervical cancer. So you can imagine that if they are not informed, the information that they're going to be given to their children will be inadequate. And then I spoke about access to services, the disparity that we have in our communities. Other communities are much more advantaged, and therefore access will be better off. And those communities wherein only service that are available is basic health services, they may not be able to cater for the screening that we have talked about this afternoon. And then lastly, maybe the issue of stigma. One of the aims of this webinar is to try and to destigmatize cervical cancers. Elsewhere, you find that people, because of the stigma that they attach, is not supposed to happen, they then delay seeking help, and therefore they don't disclose their condition, and in that case, they don't get access to the necessary medication. But the take-off message from this webinar is that screening is key. Remember, we said that screening is meant for people who are asymptomatic, but however, there will be those who are diagnosed. Treatment is available, as we have learned from our specialists this afternoon. So we hope that this webinar was informative. Feel free in the channel of our of GBC, a church at our doorstep. We also, from our department, EMS, we have EMS at the doorstep of our services. If people still need more information, more clarity, feel free to contact us, and then we'll be able to provide the information that we need. Thank you.
Wow, thank you so much. I know we have run out of time, so I'm gonna give Dr. Taukubong and Dr. Mbogota just maybe under a minute each, just to give us your closing remarks. And I must say to those people who have posted, I know people are asking us to cover certain topics. I must just let you know, watch the space. We see what you want, and we do have a lineup of topics that I think are going to be quite relevant to everyone, but please give us those that feedback in terms of what you want to see more of. But we noted some of the comments regarding some of the topics that people would want to see. Dr. Mbogota, just your closing remarks.
Yes, thank you very much. I think the one thing that I would want to address in my closing remarks is this thing called colposcopy. So when you've had a pap smear that's abnormal or a HPV test that's abnormal, a colposcope is basically a microscope that we use to look at the mouth of the womb, and it magnifies. We put in some, for lack of a better word, we put in vinegar, and the abnormal cells show up. And then we actually biopsy, take pieces of those abnormal areas, or we cut out the abnormal area, and then send it to the laboratory to make sure that all the abnormal cells have been cut out and the area which we've cut is free of abnormal cells. Yes, the question was asked, can these abnormal cells recur? Yes, they may recur if not all of them have been removed, but they may still recur de novo. Therefore, even if you've had a colposcope with a biopsy or a lead or a cone biopsy, still you need to do screening. And I think we can't emphasize it enough. It's screening to prevent going to the oncologist. I think we need to render the oncologist jobless by screening. Thank you.
Dr. Taukubong, we don't want you to have a job. In closing, what are you going to say to that?
The job opportunities are multiple. What I want to say is, on our part, I think we must screen more. We need to address this issue. It's a preventative, it's a curative. We would love to catch you in your early stages, and it's something that we can do something to give back to our community. So our role as healthcare workers, from district right down to tertiary to the lowest of our clinics, the lowest of our clinics are actually the most important people, because they must refer patients earlier and give the results of those pap smears, because there's a delay. So my cry is only to that level. Thank you.
Awesome. Thank you so much. I mean, this was our first webinar. I think it went well. Thank you to our leaders here and our experts. And thank you again to the leadership of our church for being such visionaries. I think this information is not only going to reach our congregants, but it's going to go beyond. And I think as Grace Bible Church, we should be leaders in healthcare, and just making sure that we pass this information to many more people as we lead the movement towards elimination of cervical cancer. So look out for some of our topics that are going to be coming in our next webinars. We are going to be inviting experts in every topic so that we can give you the best information that will help you to lead a healthier life. I just want to thank everyone who has joined. Thanks again to Ma Bishop and Bishop for providing us with this platform. We really cannot thank them enough, because this is the best way of making sure that the information reaches the people that need it. And I think on that note, I'm going to close the session and thank my experts again, and really bless everyone and say, may we have a productive and a blessed week until we meet again. And yeah, thank you so much. And thanks to Bawo for making it happen for us. We cannot be able to do this without him. So thank you so much to our IT team as well. Thank you.
Thank you.
Thank you.